Hello, welcome everyone to the second session of QRS series. Today we will deal with bronchiolitis in short. It is a important topic for pediatric section, for UG also and for PG students also. So let's revise bronchiolitis quickly. What is wheeze? First of all, we will see what is wheeze. Wheeze is the production of musical continuous sound that originates in narrow airways. When the airways gets narrow, there is a musical whistling-like sound which is produced. It is known as wheeze, and it is heard on the expiration as a result of airway obstruction. So this is normal airway. If this airway gets constricted, then it will produce whistling effect if the air passage through this narrowed airway. So and it is usually mostly heard in expiratory phase of the breathing. So this is wheeze. Now, what are the differential diagnoses of wheeze in infants? If you get an infant with the wheezing, then the cause may be infection, asthma, anatomic abnormalities of the air passages, which causes narrowing of air passage, or any mucociliary clearance disorders like cystic fibrosis or any pancreatic insufficiency. And aspiration may also cause wheezing in infants. So these are the few common wheeze. Now you can elaborate all these points, all the types of infections which commonly present with wheeze, asthma, Walry, anatomic abnormalities, laryngeal abnormalities, mucociliary clearance, already I have stated the examples, and aspiration pneumonia. These are the causes of wheeze in infants. Actually, asthma is not a proper term exactly. In infants, you can't tag them asthma, but any wheeze associated infection may lead to wheeze in infants. Okay, now let's move on to acute bronchiolitis. The clinical picture produced by several different viral lower respiratory tract infections in infants and very young children. The lower respiratory tract is involved, and mostly it is caused by viral infections. What are the RS findings usually seen? Patient may present with tachypnea, wheezing, crackles, rhonchi, which result from inflammation of the small airways. So point to be remember is commonly viral infections or the lower respiratory tracts and small airways, not the larger airways. Small airways are involved, and common age group involved in bronchiolitis is less than 2 years. Some books says it's less than 1 year, some say it's less than 2 years. So commonly 6 months to 2 year child usually presents with bronchiolitis. Next is pathophysiology of bronchiolitis. It's characterized by bronchiolar obstruction, lower airway obstruction with edema, mucus, and cellular debris. Resistance to small air passages is increased during both inspiration and exhalation. So inspiration and expiration, both phases have resistance due to obstruction in small air passages caused by edema, mucus, and cellular debris. The radius of an airway is smaller during expiration. So usually during expiration, the radius of the airway is smaller, and it leads to respiratory obstruction and leads to expiratory wheezing, air trapping, and lung hyperinflation. So usually, so this can be a good viva question that in bronchiolitis, the air passage get narrowed, and the increase in resistance is both during inspiration as well as exhalation. But then why expiratory wheeze is more common? Because the radius of an airway is smaller during expiration. So these are small conceptual physiological questions which participates in pathophysiology of that particular disease. Now in severe or complete obstruction, trapped distal air gets reabsorbed and child develops atelectasis. So these are the later complications of bronchiolitis. Why atelectasis develops? Because trapped airway gets absorbed, and that leads to atelectasis of lungs. So hypoxemia occurs due to ventilation perfusion mismatch, and patient may develop hypercapnia, that is retention of carbon dioxide. So about the causative agents, respiratory syncytial virus is seen in 50% of the cases of bronchiolitis, and other agents includes metapneumovirus, rhinovirus, parainfluenza, influenza, Boca virus, and adenovirus. These are, but most common is RSV. Bronchiolitis is more common in males. If we look at the risk factors of bronchiolitis, more common in male child exposed to second-hand tobacco smoke, passive smoking, and not being breastfed, and those living in crowded conditions. So male sex, passive smoking, breastfeeding, and not having access to breastfeeding, or mother is unable to feed the baby, those babies are at risk of getting bronchiolitis in early age. And risk is also high for infants with mother who smoked during pregnancy. So these are the common risk factors for bronchiolitis. Next is how you diagnose bronchiolitis. The diagnosis of acute bronchiolitis is mostly clinical, particularly if the infant was previously healthy and presents with the first episode of wheezing. A 7-month child presents with wheezing first episode. He was all good 2 days back, and just was having mild upper respiratory symptoms like cold, cough, coryza for last 2-3 days and then suddenly developed wheeze, you can suspect bronchiolitis in that patient. And chest radiography is not routinely indicated. If you have suspected bronchiolitis, it is mostly a clinical diagnosis. How you treat bronchiolitis? Treatment is mostly supportive. Supportive treatment means you have to stabilize the vitals, and no specific treatment is available for bronchiolitis so far. Those with respiratory distress, the patient present with distress, there is hypoxia, patient is not able to feed, or apneic episodes are there, or extreme tachypneic, then the patient should be hospitalized, and hypoxemic children should receive supplemental oxygen. Humidified oxygen should be given to patients who are you suspecting to be hypoxemic. The proposed target for SpO2 was 90%. Some children may require supplemental hydration also if the patient is not feeding well. Chest physiotherapy. Now these are important points taken directly from a standard textbook, and because sometimes questions nowadays has been asked like what are the recent advances in management of bronchiolitis, or debates on recent advances of bronchiolitis is common. So these points are good if the chest physiotherapy has been extensively evaluated, but there has been no proven benefit for chest physiotherapy in children with bronchiolitis. So physiotherapy is not showing any improvement. Pharmacological agents have been proven to be ineffective in the management of bronchiolitis, and there has been a debate over the use of hypertonic saline in children with bronchiolitis for nebulization, although most studies and meta-analysis failed to demonstrate any benefit. Racemic epinephrine has not been found to improve length of stay or clinical outcome among patients with bronchiolitis, but there are some evidences to suggest that it may reduce the risk of hospitalization when used in the outpatient setting. So what it means that if the patient is in such a condition that you need to hospitalize this patient, then nebulizing the patient with racemic epinephrine does not decrease the length of stay or severity of clinical outcomes. But if in a stable patient, if you are managing that patient on outpatient basis, then if you give nebulization from racemic epinephrine, then there are decreased chances of hospitalization for that particular patient. Now, ribavirin, all of you have already heard about this, is the only currently available antiviral medication targeting respiratory syncytial virus, but it has not been currently recommended because of minimal impact on disease outcome and because it is costly and difficult to administer and associated with some toxicities. So cost is much, and the mode of administration is also quite difficult. Nebulization and different modes are to be used, and it is not proven to be efficacious or proven to decrease the disease outcomes or minimize the disease outcomes. So ribavirin is theoretically a drug for bronchiolitis because it is acting on RSV, and we have seen that RSV is causing 50% of the cases of bronchiolitis. Now, majority of deaths occur in children with complex medical conditions or comorbidities such as bronchopulmonary dysplasia, CHDs, or immunodeficiency. So, mostly all of you are postgraduate students, and you have noticed that if a normal, previously healthy, stable child with no comorbidity gets admitted with bronchiolitis during winter season, you discharge the patient in 2-3 days with minimal supplements and support. But if a child with having previous history of any significant illness or with congenital heart disease, or baby was born premature and a lengthy stay in an ICU, or any immunodeficient cases, such patient may develop severe disease in case of bronchiolitis. The median duration of symptoms in ambulatory patient is approximately 14 days. 10% may be symptomatic even for 3 weeks. So mild symptoms of bronchiolitis may even persist for 14 days to 3 weeks. Now, how you can prevent bronchiolitis? Prevention is meticulous hand hygiene is the best measure to prevent transmission of virus, because here again you have to prevent the transmission of virus. If in a ward you are having a patient with bronchiolitis, a small baby, and you are not following the hand hygiene, then the health workers even can spread to other patients. So for high risk population, palivizumab is a drug that is an intramuscular monoclonal antibody for RSV F protein, or respiratory syncytial virus protein, may be given as a prophylactic agent for high risk population. But in our country, this has not been started so far. We are not using such things, and it is just for studies, and they have now some recommendations in some Western countries of giving palivizumab to immunocompromised patients. Okay, so this is the way you prevent. Now, US guidelines suggest use for children born at less than 29 weeks completed gestation, or those with significant heart disease or chronic lung disease of prematurity like bronchopulmonary dysphasia. They are using palivizumab in such patients only. So this was in short about bronchiolitis. You can definitely write short note on bronchiolitis after going through this video and these slides in your theory examination. Thank you very much. For more videos, you can subscribe to our channel. YouTube handle or channel is @Shishukare. Thank you very much.